Welcome to the deep dive. Today we're venturing into a realm of vascular surgery that profoundly alters lives, upper extremity amputation.
That's right. And for this exploration, our trusted guide is, as usual, Rutherford's Vascular Surgery and Endovascular Therapy 10th edition. We've really dug into the chapters on upper limb arterial disease and amputation.
Okay, let's unpack this because, when we consider the loss of an arm or hand, it's crucial to recognize that the surgery itself is really just the opening chapter, isn't it?
Absolutely. It's the start of a much longer story.
Yeah.
We're talking about significant challenges, rehabilitative, social, financial, psychological. It's a whole journey.
Right, the impact is huge.
It really resonates.
Mhm.
And while maybe upper extremity amputations seem less common than lower limb ones, the numbers are still pretty significant. Back around 2005, something like a third of the 1.6 million amputees in the U.S. had upper limb loss.
Wow, a third.
Yeah. And of the estimated 185,000 amputations each year, maybe 10% to 25% involve the arm and hand.
And here's something I found really interesting. Even though the total number of amputations is set to, double in the next few decades, the proportion of upper extremity cases, that's expected to stay pretty much the same.
That's the projection, yeah.
But it's also key to note that the vast majority, something like 93%, are actually minor amputations, so wrist or fingers.
Exactly, which underscores just how broad this issue is. I mean, from losing a fingertip to a really major four-quarter amputation, the effects, functionally and emotionally, they vary massively.
So what's our main goal today, then?
Well, our primary mission here is to really get into the causes, the key factors in managing these cases, and, the long-term outcomes. We want to give you a richer understanding of this, well, complex area of vascular surgery.
Okay, so let's start right at the beginning. The causes. Why do these amputations happen? What are the main etiological factors?
Well, the big one, by far, is trauma.
Hmm.
We're talking 80 to 90% of cases.
80 to 90%. Wow.
Yeah. And it typically hits a younger group, average age maybe 20 to 40, and mostly men. The workplace accidents, major injuries, things like that.
That's a huge difference from lower extremity amputations, right? Where vascular disease is king.
Absolutely. Night and day, almost. Lower limb, it's nearly 80% vascular disease.
Yeah.
In the arm, vascular issues are definitely a factor, but much less so, maybe around 7% of amputations.
So what else causes them besides trauma and that 7% vascular?
Well, you've got tumors, though that's rare, less than 1%. Infection, sometimes congenital anomalies being born with issues, and even iatrogenic complications.
Iatrogenic, meaning caused by medical treatment.
Exactly. Things like complications from arterial lines or catheterization, unfortunately.
Okay, so let's drill down on those non-traumatic vascular causes then. You said atherosclerosis, hardening of the arteries, is less common in the arms than legs.
That's right, much less common. When ischemia, lack of blood flow, leads to amputation in the arm without trauma, it's often due to things like embolization.
Like a clot travel.
Precisely. A clot travels from, say, the heart or a bigger artery and gets stuck in a smaller arm vessel. We also see things like vibration-induced white finger, from using vibrating tools.
Right, I've heard of that.
And hypothenar hammer syndrome, basically, damage to an artery in the palm from repetitive impact. Then there are some athletic things.
Like what?
Quadrilateral space syndrome, or sometimes arterial thoracic outlet compression, which can actually lead to a subclavian aneurysm, a bulge in that main artery under the collarbone. And sadly, drug use causing arterial injury is also a factor.
That's quite a mix of vascular problems.
Yeah.
Any other arterial disorders to mention?
Yeah, a few others. Things like vasospastic disorders, Raynaud disease being the classic example, different types of vasculitis, inflammation of the blood vessels, small vessel diseases like Buerger disease, which is heavily linked to smoking,
Ah, burgers.
and even radiation-induced arteritis, damage from radiation therapy. So
Yep.
yeah, the arm's vascular system can be affected in many ways, even if it's not discussed as often as the legs.
Now, Rutherford also mentions insights from military conflicts, like OIOE. What did we learn there?
Those experiences gave us a huge amount of data on traumatic vascular injuries. And interestingly, even though the rates of nerve and vessel damage were similar in arms and legs in combat,
Yeah.
the amputation rate for arms was significantly lower than for legs.
Huh. Why is that?
It really highlights the potential for limb salvage in the arm. If you can successfully restore blood flow, revascularize quickly after a severe injury, the chances of saving the arm go way up. Aggressive attempts often work.
And the text talks about reimplantation actually reattaching a severed arm or hand. That sounds incredibly important.
Oh, absolutely crucial. The evidence suggests that trying reimplantation after a traumatic upper extremity amputation leads to better patient-reported outcomes compared to just tightening up the stump and going straight to a prosthesis.
So keeping the original limb, even if it's damaged, feels better to the patient than the best prosthesis.
It seems so, generally speaking. Better perceived function, maybe more natural sensation, better quality of life reported by the patients themselves.
It also mentions the visibility of these injuries in military personnel had a wider impact.
Definitely. It raised public awareness, generated more societal support, and that, in turn, kind of pushed advancements in prosthetics, therapy, rehabilitation, specifically for the upper limb.
That's a positive.
It is, but there's a downside. A return to active duty for these service members is still very rare. And they also have a higher likelihood of PTSD compared to other amputees. It's a significant psychological hit.
Yeah, that makes sense. Okay, let's shift back to the non-traumatic cases. If amputation is on the table, what's the first step?
The absolute priority is treating the underlying problem aggressively.
Mm.
So, Buerger disease. Stop smoking completely. Acute clot. Maybe a thromboembectomy, surgery to remove it, followed by anticoagulants.
So save the limb if at all possible.
Always the first goal. Conservatism is key. Preserve every bit of tissue you can. And if amputation looks unavoidable, giving it time to the ischemic tissue to clearly demarcate.
Demarcate, meaning show exactly where the tissue is dead versus alive.
Exactly. Letting that line become clear can often mean a less extensive, a lower level of amputation, and avoiding things that constrict blood vessels' nicotine. Even caffeine is important for healing.
Okay, so the decision is made, amputation is necessary. What are the big principles guiding the surgery itself?
Well, for trauma, it's usually staged. First, clean out the bad tissue, stabilize things. Definitive closure and deciding the final level comes later.
That's different from the leg.
Somewhat, yeah. In the lower extremity, often the early focus is getting good soft tissue coverage for a prosthesis. In the arm, you need function and acceptable appearance, so you don't rush the final decision on the amputation level right away.
That staged approach,
Yeah.
what does it involve?
Usually sequential debridement, carefully removing non-viable tissue multiple times if needed, then letting it rest, maybe using advanced wound care like negative pressure therapy.
Wound vacs.
Right, those have really helped, and it prepare the wound bed for a good closure later on. And like we said, better prosthetics now really help with the functional and emotional recovery side.
Sounds very tailored to the individual. What kind of factors influence the surgical plan?
Oh, lots of things. The cause, obviously.
Mm-hmm.
Patient's age, their general health, which hand is dominant, their job, hobbies, any other injuries, their overall condition, what rehab is available, even cultural factors can play a role. It's a whole picture.
And how do surgeons figure out the right level to amputate? What guides that?
A really thorough arterial assessment is critical. Physical exam, feeling pulses, checking skin warmth, but also non-invasive studies, duplex ultrasound to see the blood flow, measuring pressures at different points.
What kind of pressures tell you if it's likely to heal?
Well, things like pulse volume recordings, photoplethysmography, laser Doppler, transcutaneous oxygen TCPO2, it's maybe less studied than in the leg, but the principle's the same. You need enough blood flow for healing. For the hand, for example, you'd like finger pressures over 40 millimeter Hg, wrist pressure over 60 millimeter Hg. Gives you a better chance.
Now, Rutherford stresses preserving length, but there's a but. Can you explain that balance?
Yeah, you want to keep as much length as possible for function, right? But, and this is the key, you have to balance that against the chances of it actually healing well. A longer stump might heal poorly if the blood supply is iffy.
Makes sense.
But one really crucial goal, keep the elbow joint if you possibly can. That makes a massive difference for using a prosthesis later.
It's amazing how much soft tissue coverage options have improved. It's not the main thing limiting the amputation level anymore.
Not like it used to be, no. Skin grafts, free flaps, moving tissue with its own blood supply from somewhere else, composite tissue transfer. These have revolutionized things. We're less reliant on just the local tissue being available.
Are skin grafts good enough for prosthetic use?
They can be okay for smaller areas. It's sometimes they aren't durable enough for the wear and tear of a prosthesis socket. Free tissue transfer, like taking tissue from the thigh or back, often gives better quality tissue and avoids issues like joint stiffness you might get with older flap techniques.
Neuroma prevention. The text calls that challenging. What's a neuroma and how do you try to stop them?
So a neuroma is basically a painful little ball of nerve endings that forms where a nerve has been cut. The nerve tries to regrow, but it gets tangled up.
Ouch.
Yeah, they can cause sharp burning pain. You can't totally prevent them because nerves just do that. The goal is to minimize painful ones. So during surgery, you find the nerve end, gently pull it out a bit, cut it sharply, and let it retract back into healthy, soft muscle tissue away from pressure points or scars.
And after surgery.
Early therapy is key. Desensitization, getting the stump used to different feelings. Sensory re-education. There are also newer surgical techniques like targeted reinnervation or nerve unions that might help reduce pain and even improve control of myoelectric prostheses.
What about the bones? How are they handled?
Getting the bone contour right is vital. For looks, sure, but really for a comfortable prosthetic fit, you don't want sharp edges or weird lumps. That means cleaning up any damaged bone properly and smoothing the end, paying attention to the periosteum, that membrane covering the bone. Especially at joints, you need to manage the natural flares of the bone so they don't cause fitting problems.
And lastly, on general principles, tendon management. Sounds like it's different in the hand versus higher up.
That's a sharp observation.
Yeah.
In the hand, with its really delicate balance of flexor and extensor tendons, you generally avoid things like myodesis sewing tendon to bone or myoplasty sewing tendon to muscle. Messing with that balance can hurt overall function.
But higher up.
Higher up, like in the forearm or upper arm, those techniques can be really valuable. The muscle balance isn't quite as intricate, and it can help provide better padding and potentially better prosthetic control.
Okay, let's get specific. Fingertip amputations. Sound like these are super common.
Extremely common. Crushing injuries, kitchen accidents, you name it. People often bring the fingertip in, but trying to surgically reattach it, microsurgery. Usually not practical, the vessels are just too tiny.
So just sewing it back on doesn't work.
Generally, no. That's called composite reattachment. It rarely survives because there's no blood supply reestablished, and the damage is often wider than the clean cut suggests. Maybe in very young kids, there's a slightly better chance, but usually not.
So what's the usual surgical plan for a fingertip?
Well, if the little piece of bone at the end, the distal phalanx, isn't too messed up and tendons are still attached, you try to save it for length. If not, you might disarticulate, amputate through that last joint. Critically, you avoid sewing the flexor tendon over the tip or to the extensor. That can mess up your grip strength and the rest of the hand. The quadriga effect, they call it, like pulling one horse back, slows the whole team. And you want to leave enough nail bed so the nail can regrow okay.
And the soft tissues and nerves at the tip.
You smooth the bone end so it's well covered. Find the little digital nerves, pull them gently, cut them sharply so they retract back about 1 centimeter. Helps avoid those painful neuromas right at the tip.
What about closing the skin?
If the defect is small, say less than a square centimeter, often the best thing is just let it heal on its own. Secondary intention. Surprisingly, that can sometimes give better long-term feeling and function than using flaps, which might end up numb.
But if the skin defect is bigger, then you need a graft or flap.
Exactly. If it's bigger but no bone is exposed, a skin graft is an option. You generally don't use the skin from the amputated part. It's already damaged. It doesn't take well. Though sometimes the amputated part can act as a temporary biological dressing.
Where do you get the graft skin from?
Usually untraumatized skin, from places like the side of the palm, the forearm, maybe the groin. You have to think about color match, scarring at the donor site, potential hair growth.
And local flaps are another option. What are those?
Yeah, several kinds. There's the Cutler flap, good for central tip defects. The Atasoy flap uses skin from the palm side. Palmar flaps that move tissue forward. You can even use flaps based on arteries in the forearm, which can sometimes preserve sensation.
Any downsides to flaps?
Well, regional flaps, like cross-finger flaps where you temporarily attach the injured finger to a neighboring one for skin coverage, they need immobilization. And that carries a risk of making the joint stiff, which is a significant drawback.
Okay, moving up a bit. Amputations mid-finger, or at the proximal phalanx, the bone closest to the palm.
If you can save more than half of that proximal phalanx, the finger can still be pretty functional. Managing the soft tissue is similar to fingertips. Maybe shorten the bone a little to get good closure. Tendons that aren't attached anymore, just cut them and let them retract. Nerves still need careful handling to avoid neuromas.
What if the amputation is even further up the finger, leaving less than half that first bone? Sounds tricky.
Yeah, often a stump that's short is functionally, well, kind of a nuisance. It can get in the way, interfere with the other fingers.
Yeah.
A short index finger stump makes using the middle finger for writing hard, for instance.
So what do patients do?
A cosmetic finger might work for some,
Yeah.
but many patients eventually choose to have a secondary ray amputation.
Ray amputation, meaning take the whole finger and its bone in the palm out.
Exactly. Remove the whole ray right back to the base. But importantly, that's usually not the first surgery offered. The patient needs to decide if the short stump is bothering them enough functionally.
That ray amputation, it's mentioned as sometimes looking better, especially for the index finger.
It can, yes.
Yeah.
It streamlines the hand's appearance. The mergery involves removing the metacarpal bone in the palm, too. You have to be really careful reattaching the remaining muscles and tendons properly to keep good hand strength.
Are there risks?
Well, it narrows the palm slightly, maybe 20–25%. And sometimes there's a bit more post-op discomfort than a simple finger amputation. But overall, it's usually functionally good, looks acceptable, and patients tend to be quite satisfied.
Now, the thumb, obviously vital. What's the approach there?
Absolutely critical. The thumb is like 40% of hand function.
Yeah.
So rule number one is save it if you possibly can. Reimplantation should always be considered, even if it's been badly torn off.
What if amputation is unavoidable?
Well, an amputation just through the joint in the thumb, the IP joint, can still leave a very functional thumb because you keep that crucial opposition movement pinching and grasping.
And more proximal thumb amputations.
Closer to the wrist. Those need careful planning for soft tissue coverage, maybe rotational flaps, advancement flaps, even free flaps. And it's a very proximal loss. You might consider reconstruction like pellicization.
Pellicization. Moving another finger over.
Yeah, usually the index finger is surgically repositioned to act as a thumb. Or maybe bone grafting to lengthen what's left, distraction osteogenesis, or even a toe-to-thumb transfer, all aimed at restoring that vital opposition.
Okay, let's move to the hand and wrist level. Principle here seems to be save everything possible.
Absolutely. Even a short palm, something that looks non-functional, can be incredibly useful as an assist hand, often more useful than a prosthesis alone.
What about specific levels like transcarpal or wrist disarticulation?
A transcarpal amputation through the wrist bones is great because it keeps forearm rotation, pronation, and supination, and some wrist movement. That helps with prosthetic fitting. Wrist disarticulation through the joint itself is usually preferred over cutting the forearm bones higher up because it also saves that forearm rotation, though you lose wrist flexion extension.
Nerve management must be tricky there.
Very. You've got the big ones, ulnar, median, superficial radial nerve, all ending there. Got to manage them carefully to minimize painful neuromas. Even smaller cutaneous nerves need attention.
Forearm amputations, then. Is there an ideal spot?
Generally, the sweet spot is considered the junction of the middle and distal thirds of the forearm.
Why not further down?
The very distal third has less muscle padding, so the skin over the bone is more vulnerable to breaking down, especially with prosthetic use or if there are blood flow issues.
And preserving the elbow is still paramount.
Hugely important. If you end up with a really short below elbow stump, surgeons might even consider complex things like free flaps for better padding, or distraction osteogenesis to lengthen the bone just to save the elbow function. But usually, heroic efforts aren't needed.
Reconstruction is usually a prosthesis.
Typically, yes. Though for people with bilateral forearm amputations, there's an interesting procedure called the Krukenberg procedure. It surgically separates the two forearm bones, the radius and ulna, to create a kind of sensate pincer.
Wow. Functional, but maybe looks unusual.
Exactly. It significantly improves function for daily tasks if you have no hands, but the appearance is unconventional, a real trade-off between function and cosmetics.
Elbow disarticulation, taking it off right at the joint. When is that done?
That's preferred if the elbow joint itself is just too damaged or diseased to save, rather than cutting the humerus bone just above it.
What are the advantages?
It preserves the full length of the upper arm bone, the humerus, and critically, it allows the natural rotation of the humerus to be transmitted to the prosthesis, which feels more intuitive. Plus, the wide bony flares at the end of the humerus, the condyles, give a good stable base for the prosthesis socket.
How is the end covered?
Usually with a muscle flap. Prosthetic elbow joints can be internal or external. External ones tend to be more durable but can make the arm look longer. There's also something called an angulation osteotomy, more common in Europe, reshaping the bone end, but it's less popular in the U.S., maybe due to cosmetic concerns.
And upper arm amputations, above the elbow, similar principles.
Pretty similar surgical principles, yes. Careful handling of bone, muscle, nerves, skin. An amputation just above the condyles, a transcondylar amputation, functions much like an elbow disarticulation for prosthetic fitting.
What about higher up the arm?
More proximal amputations mean the prosthesis needs its own elbow locking mechanism, and usually a turntable for rotation, since you lose shoulder rotation control. Reimplantation is still sometimes possible even high up, but needs a big team effort.
Shorter stumps are harder to fit.
Much harder. Sometimes complex reconstructions with free flaps or even transferring bone, like the fibula from the leg, are considered. Distraction osteogenesis might be used to lengthen the humerus. The main message is, avoid really high amputations if you can. Maximize that humeral length, even if the plan is ultimately for a shoulder-level prosthesis.
Which brings us to the highest levels. Shoulder disarticulation and forequarter amputation sounds like the toughest challenges.
Absolutely the most complex. You lose so many muscles needed to control a prosthesis, and just getting a stable, comfortable socket fit is incredibly difficult.
Is there a difference between them functionally?
Well, with a shoulder disarticulation, removing the arm at the joint, you still have the shoulder blade, the scapula. Its movement can potentially be used to control a prosthesis, though it takes a lot of therapy and the function is often limited.
And forequarter?
Forequarter amputation is much bigger. Surgery, arm, shoulder, clavicle, scapula, all removed. Usually done for aggressive cancers. Honestly, there's very little hope for meaningful functional restoration with current prosthetics after that.
Surgical techniques must be complex too.
Yes, involving large flaps, often using deltoid or pectoral muscle and skin. Trying to reattach remaining muscles, like the latissimus dorsi or pectoralis major, to anchor points can sometimes help with prosthetic control. But the basic principles still apply. Smooth bone, careful nerve and muscle handling, good soft tissue coverage.
Okay, so the surgery's done. What's the immediate post-op care like, and what can go wrong?
Post-op is about supportive care, pain control, watching the site. Usually use drains for a short time to prevent hematoma or seroma blood or fluid collection. Get those out early to cut infection risk. Compressive dressings right away to shape the limb and control swelling.
Start moving early.
Definitely. Range of motion exercises for any joints not amputated should start pretty much immediately.
Complications.
Locally, infection is actually pretty rare in the upper limb, less than 5%. Wound healing problems can occur. If complex reconstructions like free flaps were done, they can sometimes fail early on, maybe 3–8% risk. Systemically, you worry about sepsis, issues from associated injuries, or underlying disease. Rhabdomyolysis, muscle breakdown can happen, but less common than in leg amputations.
Is revision surgery common?
Especially after trauma, yes. One study of combat amputees found like 42% needed revisions later. But revisions can actually improve prosthetic use and outcomes.
Oh, and interestingly, below-elbow amputees seem to report more phantom limb pain.
Right, phantom limb pain, that's a big one. What does Rutherford say about it in the upper extremity? Phantom sensations feeling the limb is still there are almost universal. But actual long-term, troublesome phantom pain happens in a lot of people, maybe 40–80%.
That's a huge range. How is it treated?
It's tough. Needs a mix of approaches, medications, sometimes surgery, psychological support, things like nerve stimulation. New to research is looking at changes in the brain's motor cortex, which might lead to better treatments down the line, and there's some suggestion losing your dominant hand might predict worse phantom pain.
Recovery is clearly more than just physical. Psychosocial rehab must be vital.
Absolutely critical. Upper extremity amputees tend to have higher rates of things like depression, anxiety, PTSD compared to lower limb amputees. Estimates are maybe 30–40% might need psychological care to help them cope and adjust.
And the physical rehab process itself.
It's complex, often long. And historically, upper limb prosthetic tech has kind of lagged behind lower limbs, especially for fine motor control.
What are the main goals of physical rehab?
Key things are shaping the residual limb for a prosthesis, desensitizing it, keeping full motion in remaining joints, keeping the skin healthy, strengthening the remaining muscles for control, getting the person independent in daily tasks, and really exploring all the prosthetic options. It's about reducing pain and maximizing function, whether that includes a prosthesis or not.
Let's talk prosthesis then. What are the main types?
Generally, three main buckets. First, aesthetic ones mainly for looks, often silicone, very lifelike, but minimal function.
Okay.
Second, body-powered. These are mechanical, controlled by body movements, usually via harness and cables. They're typically very durable, good for physical work.
And the third?
Myoelectric. These use electrical signals from your remaining muscles to control motors in the prosthesis, wrist rotation, maybe even finger movement in advanced ones.
Sounds high-tech.
It is. Allows more natural control, more degrees of freedom. But they're complex, expensive, and maybe not as tough for heavy-duty stuff. But this is where a lot of exciting development is happening, like those advanced DARPA arms. And techniques like targeted reinnervation are making control much more intuitive. People are even researching direct brain control.
Wow. What about hand transplantation? Is that a real option?
It is, but highly specialized. The first one back in '64 failed. But since then, with better surgery and anti-rejection drugs, over 70 have been done.
And the results?
Physical results are often rated fair. Functional outcomes may be good, especially in bilateral cases with long follow-up. But it's incredibly demanding surgery, requires lifelong immunosuppression, and there's always the risk of chronic rejection. Studies on whether it's worth it from a health utility perspective are still kind of ongoing.
So finally, looking long term, what's the picture for people after upper extremity amputation?
It's hard to generalize because the causes, levels, and patients are so varied. Late stem prevention surgery isn't uncommon, maybe due to disease progression or prosthesis problems.
Do people use their prostheses long term?
Attitudes can be mixed, especially for higher level amputations, like above elbow. A significant number might choose not to use them regularly. Even with hand-level amputations, getting back to all previous activities and work can be tough, though being employed seems to correlate positively with using a prosthesis.
So ongoing support is key.
Absolutely essential. Whether they use a prosthesis or not, multidisciplinary care, physical, psychological, social, vocational, is crucial for long-term well-being.
Okay, so to wrap up this deep dive, we've really covered the waterfront here. The diverse causes, from trauma to rare vascular issues, the critical surgical decisions, the rehab journey, the range of prosthetics, and just the profound life impact.
Exactly. And while it might be less common than lower limb loss, upper extremity amputation throws up a really unique set of challenges. But it's also heartening to see the constant progress in technology and rehab, really pushing to improve outcomes.
It does make you think, though. With things moving so fast in areas like neural interfaces, AI, advanced materials, what breakthroughs are next? Could we see something that fundamentally changes what's possible for people living with upper extremity amputation? It's definitely a space to watch. Thank you for joining us for this deep dive.